So I'm going to go ahead and talk and update some of this data that, as many of you may have already seen, and talk about both literotrectinib and selotrectinib. TRK biology, it's interesting. So some of you may know that these TRK receptors were first identified as receptors in neural functions. TRK-A primarily in signaling, TRK-B in the regulation of movement and memory, appetite, and C in proprioception. This is relevant specifically for the toxicities that we're going to deal with TRK inhibitors. It was in the 1980s when folks discovered that certain cancer cells develop fusion proteins, partnering with some of these NTRK genes plus another partner, leading to both dimerization and oncogenic addiction. And to date, we've now identified many different NTRK gene fusion types, specific certain tumors. As we continue to profile, NGS profiling becomes more common, and we'll identify further gene fusion types.
NTRK gene fusions are found in multiple cancers, and probably the best way to identify, divvy them up, is adult versus pediatric, rare versus common. In general, in pediatric tumors, which are relatively rare tumors, there are very common, almost pathognomonic tumor types, such as infantile fibrosarcoma, secretory breast cancers. More common tumors in pediatrics, such as gliomas, about 7%, and also in thyroid, up to 26% of pediatric patients will harbor these NTRK fusions. In adults, again, it's divided primarily into very rare subsets, such as salivary gland tumors, which are almost pathognomonic, secretory breasts, also almost pathognomonic, and then other more common tumor types, but albeit still relatively high prevalence, such as thyroid cancer, and also other sarcomas. So I'm going to talk today about two specific inhibitors, which many of you are familiar with, literotrectinib and entrectinib. So I want to start off with this patient. This was patient number, I think, 1 or 2 on the phase 1 literotrectinib study. She was a 42-year-old female, young mom with undifferentiated sarcoma who had progressed through multiple lines of chemotherapy, sorafenib, et cetera, and was identified to have an NTRK fusion. She went on the literotrectinib study and had this incredible resolution of her disease. She is still on study almost 6 years later. And it tells you just the power of identifying these patients and the power of these NTRK inhibitors in general. So I'm going to talk a little bit about literotrectinib. Literotrectinib, as you know, is a very specific, much more specific than some of the other drugs like entrectinib to TRK specifically. It has a very IC50 of 5 to 11 nanometers. And one argument that is that this drug also has a very slow dissociation rate. The initial data included 55 patients, and the most recent data we presented last year really included these 3 trials: the adult phase 1, the SCOUT phase 1 and 2, and the NAVIGATE phase 2 study. The most recent data shows close to 175 patients with TRK fusion cancers. This is the larger data set of closely 175 patients. And as you can see, the response rates remain still very robust, even with the expansion from 55 to 175, close to 20% of complete responders, and a partial response close to 80% across, irregardless of histology, again, irregardless of age or NTRK fusion. And it's one of these rare molecules I've ever seen where you go from phase 1, phase 2, and larger expansions where it seems to be even getting better after each of the data sets. And both the duration of response and overall survival have yet to be reached in this latest data set. The progression-free survival is about 37 months. So one of the questions about these drugs is whether or not they cross the blood-brain barrier, affect CNS metastasis. This data was presented by Dr. Drillin several years ago, last ASCO, And as you can see here, we had about 24 patients with intracranial disease, 18 of them with CNS primary and 6 patients with non-primary. And this was the breakdown of the patients who specifically had intracranial disease, brain metastasis, mostly non-small cell lung and thyroid in 6 of these patients. And the overall, in the 5 patients that were actually evaluable, you could see that the response rates were still very robust, about 60%. So this drug can affect patients with CNS disease. And again, this is the duration and also the response. So I'm going to talk about entrectinib, which is the other drug that is currently approved for NTRK positive patients. This was, again, pooled analysis from about 55 patients of the STARK2, STARK1, and the ALK study. One key difference, as you all know, is that NTRK also targets ALK, ROS, and a number of other specific targets. This is, again, the breakdown of the tumor types, sarcoma being the most common, as with larotrectinib. They had perhaps a higher number of patients who were possibly non-small cell lung cancer, given that they were also looking for ALK-ROS patients. And again, similar to larotrectinib, they saw high response rate, albeit lower, at about 57% response rate. Again, irregardless of histology, and also showing activity in the CNS tumors. And duration of response, progression-free overall survival. Their data is a little bit was less mature at the time of this presentation, but median duration of response was 10 months, progression-free survival 11, overall survival at 21. And again, CNS metastasis similar to larotrectinib, high response rates, close to 55% response rate. So what are the main differences? Again, the main differences here between laro and entrectinib is that one is very selective, larotrectinib, versus multi-kinase for entrectinib. Response rates, albeit are higher for larotrectinib at 78% versus 57%. Response rates are very similar. Median progression-free survival, it does appear to be longer with larotrectinib, and that may partly be because the data is a little bit less mature in entrectinib, but clearly you can see here that there is a longer progression-free survival, and the overall survival, it's hard to compare right now because we have not reached it with laro, but 21, but still very, very long for both drugs. And adverse events, the vast majority of adverse events, which our next speaker will speak about, is mostly grade 1 and 2, fatigue being the most common in laro, and dysgeusia in entrectinib. Fusions are truly oncogenic drivers. And as you can see here, NTRK particularly is very key in driving these patients who have NTRK fusion cancers. And these TRK inhibitors, either laro or entrectinib, can really be truly transformative molecules. And I think really the key point here is that we really need to find these patients. They're rare, but if you can find them, you can really make an impact in these patients' lives. You know, I mentioned early that really kind of what was remarkable about the development of this, not only how quickly we were able to transition from first in human molecule to approval, but both, you know, larotrectinib and other companies were already beginning to develop models and specifically molecules to target what was anticipated to become resistant mechanisms. And as you can see here, early on, we were able to, the investigators were able to identify that there were acquired mutations that developed, that led to acquired resistance, particularly what's called the solvent front mutations, shown here in the 595R, and also what are called gatekeeper mutations near the activation loop. So preclinical models were done, and Loxo, to their benefit, began developing a molecule that would target that. And even before we actually got the phase 1 trial up and running, Alex and those folks at MSK were able to test, hypothesize through compassionate use, some of these patients who are developing resistance to larotrectinib. So you can see here, there's really 3 major acquired resistance mutations. solvent front and something called the DFG mutations and these gatekeeper mutations. But we know that there are also, the vast majority of resistant mutations are listed here, as I shared, but there are what appears to be other off-target resistance. There were some case reports showing that patients could also develop either MET amplification, BRAF, and kind of bypass signaling that would lead to resistance. So really, there's really to date 2 molecules, selatrectinib, which I'm also a PI of and currently running, and that hopefully will end soon, and we'll have that data to really fully share with you all. And then there's ongoing study with repotrectinib. Now, repotrectinib's primary data set has been in non-resistant patients, but in just NTRK 1, 2, or 3. But theoretically, this drug can also target solvent front, DFG, and gatekeeper. So this is selatrectinib, as again was developed even before we finished the larotrectinib trial. And I want to end with this. This was my patient. She was a 58-year-old female with anaplastic thyroid cancer who had this NTRK1 fusion, got on study, did incredibly well, had a PR for close to 9 months, but developed clearly a solvent front mutation. And we were able to get her on the selinectra trial. And as you can see here, she had also a remarkable response. Literally she got on and within hours, she felt 100% better. And she was on the study for also about 9 months. Unfortunately, she did eventually progress. And so what it tells you is that we do kind of have the next generation. The question is will there be a 3rd generation, and we'll see if that comes about.